Hey there everybody, thanks for tuning into this last installment of the shoulder series here at PhysioDisc. We're going to be looking in this episode at shoulder impingement. We'll talk about kind of what impingement means, different types of impingement, the most common types of impingement, things that can happen if you let it go untreated, different treatment options and things like that. So hang in there with me, we're going to try to get some really helpful information to you. First things first, it's helpful to understand exactly what impingement means if we're going to talk about it the entire episode. Some of you may have been given a diagnosis or talked to somebody and told them kind of about what you had going on with your shoulder. And maybe they said that you had impingement. Well, if you do truly have impingement, it's a shoulder disorder or a shoulder injury that occurs when either the portions of the rotator cuff, the bursa in the shoulder, subacromial bursa or deltoid bursa, and we'll talk about a little bit what those are here in a little bit, or the joint capsule or other types of muscle tissue are trapped under the acromion. But basically, it's when any of those structures are pinched or trapped or compressed under that acromion. Now, the acromion is the bony projection off of the scapula. I'm going to drop a picture up there that projects anteriorly, and that is the bone or the bony projection that articulates or connects with the collarbone, and underneath that runs a supraspinatus muscle and also the subacromial bursa. Now, the bursa is a sort of a fluid-filled sac that sits usually between some type of bony prominence and some other type of soft tissue, and its purpose is basically to reduce friction or reduce the amount of stress that bony prominence or that bony projection may place on the tissue surrounding it. There are two bursa in the shoulder region. There's subacromial and the deltoid, and those both connect, or as we like to say in the medical world, they communicate with one another, meaning they touch and they maybe even share some fluid in some individuals. They basically just protect the rotator cuff from your acromion, and they also help reduce friction as it's moving in that small space the rotator cuff tendons have to move. A little fun fact for you, between the acromion and the bursa, there's about 1 to 1.5 centimeters of clearance, which is not really a whole lot. Try to put that into perspective. That's about the width of your thumb. So that's about 1.5 centimeters. So not a whole lot of space for the bursa and the rotator cuff muscles or tendons to move and have a lot of area just to do their jobs. And so it would make a lot of sense then too that if those tissues or anything in there gets inflamed, that space decreases, therefore making it much harder to move and increases the likelihood of impingement. It's really also important to note when kind of looking at this general region where impingement occurs, there are 3 different types of acromion shapes. The characteristic of, or the shape of your acromion is inborn, meaning you're born with it, you can't do anything about it. The only way that they could figure out what kind of shape your acromion is through imaging. I guess unless you're super skinny and super bony, then maybe they'd be able to see that, but I've never been either of those things, and I've not really worked with anyone who's been so skinny that I could see their acromion shape. But imaging is the best way to see that, and then the best way to fix that, if it needs fixed, I guess, is to have surgery. The 3 types are flat, curved, and hooked. Think about a flat acromion, you've got pretty good space in there. If you think about a curved acromion, you've got a little bit less, and if you've got a hooked acromion, you've got even less space, and individuals with hooked acromions are much more likely to impinge there at that spot in your shoulder. Now, impingement can occur to several different tissues, long head of biceps tendon, your joint capsule, your bursa, some of your rotator cuff tendons. But the most commonly impinged structures are the bursa and then rotator cuff tendons. And individuals who are most commonly injured are swimmers, do a lot of overhead and lots of maximal external rotation movement. Baseball pitchers or just baseball players in general as they throw and get a lot of external rotation there. And also volleyball players. They do a lot of overhead swinging and kind of this motion here. Again, a lot of external rotation. And some of those motions, other motions that like baseball players do, the batting motion, swimmers, they do different kinds of strokes, so their shoulders are in different ranges all throughout. And volleyball players also do other things that may lead or contribute to or promote impingement. But they're all doing motions that are somewhat similar to some of the motions that we have in disc golf, such as forehanding, tomahawking, throwing thumbers, anything like that. Those motions that even though they're just kind of accessory shots that we like to have in our bag, those motions can contribute to impingement just as those other athletes' respective sports. Now, a lot of impingement that occurs at the shoulder is going to happen sort of at your superior aspect or anterior aspect of the shoulder. That's just where there's a lot of decreased space. There is a significant decrease in space there for things to move around, especially if there's inflammation or you have that type 3 or the hook to chromium. And less commonly, there is impingement that can occur in the posterior aspect of the shoulder. And that happens generally between the supraspinatus and infraspinatus tendons and then the posterior glenoid rim, or the posterior rim of that shoulder socket. Now, impingement occurs for a lot of reasons, some including mechanical or some type of inflammatory response in the soft tissues inside. But most commonly, it's due to some type of inflammation to the rotator cuff tendons due to some other type of injury. So it may even be a little tweak that you're not even really aware of. Those tendons get inflamed, muscles get inflamed, bursa gets inflamed, whatever. It increases the likelihood that it will be impinged or entrapped or compressed. But like I also said, it can happen from some type of mechanical deficiency. So if you got poor mechanics or poor shoulder coordination or scapular control, that can also lead to some form of impingement. Just because you have shoulder soreness or shoulder pain in that superior or anterior or even posterior part of your shoulder does not necessarily mean that you have impingement. You could have some type of muscle strain or some type of tendonitis that's formed separate from impingement. Generally, there's going to be some type of sharp pain, either with a quick movement overhead or even with the lowering of your arm from an overhead position. There's also a pretty telltale pain pattern that kind of starts at the anterior aspect of your shoulder and kind of moves laterally out to the side of the arm. There's also going to be some type of weakness in the shoulder, and that can be secondary to pain. And what I mean is your shoulder is weak because your shoulder hurts, so you're using it less, and you get some type of atrophy or decreased muscle mass or decreased shoulder endurance. You may have a feeling of stiffness in your shoulders, predominantly in the morning, especially if you have slept on that arm. And if you have slept on that arm, you probably had pain in the night because you are increasing the compression. And there's also going to be some pain with reaching behind the back because, again, you're maximally internally rotating and then adducting across the body, which can cause pain for if you're putting a jacket or coat on, if you're trying to wipe after toileting, or if you're trying to pick a huge wedgie. Now, if you're seeing your primary care physician for shoulder pain, if you're in a state that doesn't have direct access and you can't go directly to a PT, they may want to do some type of x-ray beforehand. And that's not always a bad idea because on occasion, they will find a bone spur in that subacromial space. And if you think you've got a 1 to 1.5 centimeters of clearance in there and you even get a really small bone spur and then you get inflammation, the space is even more drastically decreased. That can really, really increase your likelihood for impingement. The gold standard, though, for looking at soft tissue injury is MRI. That's the best way to look at that soft tissue in your shoulder and determine if there's any type of injury or inflammatory response going on at the rotator cuff, tendons, muscles, or the bursa. As with the majority of the videos that PhysioDisc puts out to talk about injuries, there are special tests that physical therapists will use to determine whether or not you have some type of impingement. And I realize that I should have given the disclaimer long ago, not that I've heard any complaints or anything, but these special tests aren't perfect, right? So these special tests are used in conjunction with an evaluation by a professional, a physical therapist, to determine whether or not you have whatever condition that you're trying to rule in or rule out. These special tests, while they're great and they may give you an idea, they are not the end-all be-all. So a lot of people who are asymptomatic for impingement, when they do some of these impingement tests, they may have a positive test. And so that does not necessarily mean, though, that they have impingement. It means that they are impinging when they do this extreme motion, because these motions that you do for these special tests, especially for impingement, are not necessarily motions that are super normal, but they're kind of designed to maximally stress specific tissues, targeted tissues. So let's go ahead and take a look at probably the 3 most popular impingement tests are. You may be asking yourself, so I've been having shoulder pain. Some of those motions that Andy talked about are painful, and then I did some of those special tests, and I think that they were all positive, or a couple of them are positive, and I think that I maybe do have impingement. If you were thinking that, please go get evaluated by a professional. YouTube videos, they're great, and you can learn a lot of really cool things by going on YouTube. I figured out how to do quite a few things I would otherwise never have any idea how to do around the house or with my truck or whatever. But that doesn't make me a mechanic. That doesn't make me a construction worker or a carpenter. Those jobs are usually best left to the professionals, especially in the case of injury. That being said, if you think that you may have that, go get checked out. Don't put it off and think that you can play through it. If you're playing through impingement, or if you truly do have impingement and you decide to play through it, you really risk doing some serious damage to some of those tissues that are commonly involved, like your rotator cuff or your bursa. So for the rest of the segment, I'll be joined by my assistant here, Calvin, aka Cal Diesel. So when you leave a impingement untreated long enough, and if the rotator cuff tendons are involved, what you can eventually do is cause those tendons to fray. And as they fray, they don't work as efficiently, and ultimately that can lead to tendon tearage or failure. To help you visualize that, if you think of an old rope, as it gets old and kind of crusty, the strands start to break off of it, and it really just kind of frays and widens out. And if you think about using a frayed, worn out rope to lift anything, that's kind of scary because its structural integrity is jeopardized. It's not as strong as it once was, and that's the same goes for those tendons. If you let them be compressed long enough and worn out long enough, they'll get frayed. And repetitive injury to that bursa can lead to a lot of inflammatory response and ultimately lead to a bursitis, which is kind of tricky and lengthy to get rid of. So what do you do about shoulder impingement? So with subacromial impingement, you're going to be looking to avoid a lot of overhead motion because that overhead motion increases the compression on those structures. You're going to want to decrease the frequency in which you're going in those motions. You can continue to do things, you just modify the activity, but you're doing it in a pain-free range. So those with impingement that is occurring at the anterior portion of the shoulder, you're going to want to avoid any type of cross-body adduction or horizontal adduction. I'm not hit this guy in the head. You're just going to want to reduce the frequency at which you're doing that, not totally eliminating it, and kind of as you heal, you can progressively move back into that. Now with the posterior impingement that we talked about, which is oftentimes referred to as internal impingement, you're going to want to avoid activities or things that are going to move you into that external or maximal external rotation. Things like forehands, any type of tomahawk or thumber where you're coming overhead like that. You're going to want to avoid just that maximal external rotation. And with all of these, any type of pain that you're experiencing with a motion in the direction in which you're impinging should be avoided because that pain is because of impingement. If you are trying to decrease the inflammation that has occurred, either because of something else or is increased by the impingement, you kind of want to stay away from that sensation or continued impingement because it's kind of like a vicious cycle. You impinge, you get inflamed. You're inflamed, your likelihood to impinge increases. And then you continue impinging and inflaming and impinging and inflaming. So you kind of just want to avoid those sensations or that pain of the impingement. Common technique that I use to help treat impingement is long axis distraction of the glenohumeral joint or the shoulder joint. And we're going to take a look at a video of me doing that to myself, which is completely possible. It's crazy, I know. But I will caution you if you're doing this. It is possible to overdo it. And it is possible if you do it in the wrong directions, the wrong ways, you can injure yourself. So if you feel pain when you do this, don't do it. If you are doing it and the pain subsides, stop doing it because you've reached the desired effect. So just keep those things in mind as we take a look at this video. Now, distraction can offer a ton of relief to impingement sufferers because it helps to open the shoulder joint up and increase the space inside of the joint itself. Joint distraction, you could do it with a resistance band, you could do it on the edge of a chair or a bench, or if you're at a place that's got like a treatment plinth. I know some gyms have massage tables and things like that. If you have that at your disposal, you can do that. These things should only be performed as long as the pain persists. When you get pain relief, you should stop using the technique because, again, you don't want to do this excessively, but you've also kind of gotten what you wanted out of it. So there can be too much of a good thing, and just kind of remember that. You're going to look into do sets of about 10 to 15 second holds. There's not a real necessary number of sets. It may take longer for one person than another. I would say if you have done 5 or 6 of them and you're still not getting it, take a break from it. And maybe try it again later. Other than that self-mobilization that you can do, or those different types of self-mobilizations that you can do, the other thing that I would encourage people to do who have impingement is once you have kind of relieved some of that inflammation and you feel like you're starting to get ready to do some overhead stuff again, is to start on shoulder and scapular stability. You can do scap squeezes and shrugs and things like that before the inflammation is gone, just because you're not going to be decreasing that subacromial space with those, and that will help with scapular strengthening and increasing your shoulder endurance. But I would really wait on doing some of the other advanced techniques that I've shown you or exercises I've shown you until the pain has really subsided with a lot of overhead motion. Fortunately for you, I have covered a lot of those in previous videos. So if you are looking to do some scapular stabilization or some shoulder endurance building, go ahead and look at the past few videos in the shoulder series, and there are tons of ideas of exercises that you can do. Aside from self-mobilizations and therapeutic intervention, or if you've seen a therapist and you work through this and it's not quite working, I'm not really going to go into many of the surgical options just because those are really last case scenario type things. But another thing that an ortho specialist may want to do is give you an injection, a cortisone injection in that subacromial space to kind of help take that inflammation down. Normally I'm not a huge fan of those just because I really want to try to avoid introducing a lot of cortisone into a space that has tendinous structures like your rotator cuff, because excessive exposure to those cortisone injections has been scientifically proven to degrade tendons and make them weaker. That's almost like a last case option to go with, but I have known people who have had great success with those injections. So don't take that as me saying, don't do it, don't ever do it. Don't get 7 injections in your shoulder. That's a lot, that's excessive, and most doctors wouldn't even do that. In terms of timelines for healing, they really vary greatly, especially for impingement that involves your rotator cuff. But kind of as a general rule, it can take from anywhere up to 12 to 16 weeks of rehab to get back to full function. And if any type of tendinitis is present due to a prolonged impingement episode without seeking care and kind of decreasing that impingement motion, that could take longer. We've talked about this before. Tendons don't heal super fast. They just don't. They don't have the same type of blood supply that other structures in your body do. So it's going to take a lot longer for those to heal up, to get the good stuff into the tendons where it needs to be and help those heal up like they need to. Additionally, if there is any type of bursitis, healing is really heavily dependent on how much you avoid doing that impingement motion. Because if you repetitively impinge a bursa, it's just going to continue to be inflamed, to continue to fill up with excess fluid. Trying to progress through the kind of the bursitis protocol too quickly will almost absolutely lead to re-injury, as you're not giving that tissue enough time to calm down or build up. Kind of like a callus. There's kind of a thinking right now that the bursa can be treated like the calluses that you build up on your hands if from hard work or from working out in the gym. You know, those don't happen overnight. They take time, and sometimes you get blisters, and sometimes those blisters pop. It can be painful, but over time you can develop thicker bursa that still do their job, but are less likely to be so painful. That's it for this episode, everybody. If you have found this episode to be helpful, or you feel like you've benefited from this information, please share it. I'm sure there's someone else out there in the disc golf community that would also benefit from hearing about it. Or if you know for certain that there is a person or a group of people who would benefit from this, please direct them to our YouTube channel. Share a link with them directly. We would love to get the word out about PhysioDisc. We're giving free injury advice and rehab advice and prehab advice. So please, just like, share, subscribe as you feel inclined. You may have also noticed that I'm wearing this dope PhysioDisc sweatshirt, PhysioDisc, because bodies aren't overstable. It's kind of a play on words. So if you like the sweatshirt, it is for sale on Amazon. That's right. Daddy's selling sweatshirts on Amazon and t-shirts on Amazon. And those proceeds go directly to PhysioDisc, funding future, improving video quality, editing quality, things like that, so we can get the best product out to you. I'm really looking forward to doing a product review, so stay tuned for that. And again, thanks for tuning in. We appreciate your viewership. Stay excellent.